A very good evening to all. It gives me immense pleasure to welcome all the attendees to our yet another PG Examination Forum webinar. PG Examination Forum is the brainchild of Dr. Deepak Mishra sir, which was started with the goal to provide a unique platform for academic discussion that would benefit Optal residents across the country. We are currently a family of more than 1400 PG residents on our WhatsApp group and over 700 on the Facebook. To become a member, all you need to do is to send your name and college name to the numbers provided on the screen. You can also join us on Facebook and subscribe us on YouTube so that you do not miss out any of our videos. We have successfully conducted 11 webinars so far and the response has been overwhelming. We have crossed 5,000 viewership for all our webinars. I would also like to add that all our special invitees today are residents from PG Examination Forum Group. I'm Dr. Saloni Sinha and I'm a postgraduate from MKCT Medical College, Odisha. I'm pretty sure you'll agree that during our postgraduate journey, the most stressful time for some are our final examination, while for others, it would be writing a paper, and for a few, it could be both. So here is an attempt to help us all through this webinar under the guidance of most elite experts from over the country, who would be giving us tips and tricks so that we can give our best in our postgraduate examination. They would also be giving us insight about scientific writing to help us enhance our skills. Our chairpersons and speakers today need no introduction. They have been role models for all budding ophthalmologists and are all stalwarts of our field. It's my privilege to be welcoming them. Our chairperson for today is Dr. Rajvardhan Azad sir. Sir is Professor Emeritus of RIO IGIMS Patna. He is also the chairman of University Service Commission Bihar. He has pioneered childhood blindness program, especially retinopathy of prematurity, and in the process give vision to the future of India. Sir holds the post of Secretary of SARC Academy of Ophthalmology and is the most popular icon of young generation of ophthalmologists. We welcome you, sir. Now coming to our speakers for today, our first speaker is Dr. A.K. Khurana, sir. He is a pioneer in the field of ophthalmology. Sir is professor in SGT Medical College, Gurugram, and is the former senior professor and head of RIO PGIMS Rohtak. Sir's books are famous among not only opthal residents, but undergraduates too. We all have read and passed our exams reading Sir's book. It is a pleasure to have you here, sir. Next we have Dr. Mangatram Dogra, sir. Sir is the Director of Retina Services at Grewal Eye Institute, Chandigarh. Sir has done exemplary work on retinopathy of prematurity and has received many honors and awards for the same. He is the former professor and head of ophthalmology, Advanced Eye Institute, Eye Center, PGI Chandigarh. It is a privilege to have you here, sir. Next, we have Dr. Meenakshi Swaminathan, ma'am. She is ex-senior consultant and academic director of Shankara Netralaya, Chennai. And if you have attended any of lectures by ma'am in past, you would agree how beautifully she simplifies difficult topics like strabismus. We are so pleased to have you here with us, ma'am. Next, we have none other than Dr. Santosh Sonawar, sir. Sir is the Director of Department of Ophthalmic Plastic Surgery and Ocular Oncology and National Retinoblastoma Foundation at Center for Sight, Hyderabad. Sir is also the editor of Indian Journal of Ophthalmology and has achieved the unique distinction of being the first Indian ophthalmologist to receive the Life Achievement Honor Award, which is the highest award of American Academy of Ophthalmology conferred to its members. It is a privilege to have you here, sir. And our last speaker for the day is Dr. Vivek Gupta, sir. He is Associate Professor of Community Ophthalmology from RP Center, AIIMS, New Delhi. He would be enlightening us on a very important topic of PubMed research. We are happy to have you, sir. Now I would like to introduce our mentors. These are the people who are responsible for making these webinars possible. We have Dr. Satanshu Mathur, sir, who is Chairman of Scientific Committee Equine. Sir is also the founder of PG Examination Forum and National Convener SSTC. Sir is the Secretary of NZOS and UKSOS and owns High-Tech Eye Institute and Laser Center, Kashipur, Uttarakhand. And then we have Dr. Deepak Mishra, sir, faculty at Regional Institute of Ophthalmology, BHU Varanasi. Sir is also the founder and admin of PG Examination Forum and Chairman of Scientific Committee, UPSOS, and also National Convener at SSTC. Now I would like to welcome Rajvardhan Azad, sir. He is here for the welcome speech.
Today we are really very happy after doing so many webinars it is really proud privilege for me and for the PG Forum that we have teachers of teachers in ophthalmology with us. Dr. Rajwant Ajaz sir, Dr. Manga Dogra, Dr. Khurana sir, Santosh Unwar, Dr. Minakshi, Vivek, they all are teachers, and many of us teachers have taught many of our colleagues. So I will request Dr. Rajwant Ajaz sir, our chairperson, to give the blessing to the PGs, because they are going to appear in the exams. This webinar has been organized because of their request, because they were very worried what is good they will get, how will they give the confidence to appear in the exam and get through. Dr. Rajwant Ajaz, can you hear me? Dr. Ajaz, sir, unmute kariye apne ko. You unmute yourself, sir. Yes, sir.
Can you hear me now?
All the students.
Yes. Thank you very much, Hatansu. And I'm very happy to be here among the students. It is always, nice when I'm with the students, because for so many years we have, been in the teaching, and my first love are the students only. This is a very unique opportunity for the residents to listen to the great stalwarts in ophthalmology. As already mentioned, Dr. Ashok Khurana, everybody knows, and he is, one of the very prolific teacher. He has taught so many students, and is a very good, orator. We have with us Dr. Manga Dogra, and with whom I am very closely associated, not only in the teaching, but also in the, a special kind of retinal diseases. All of you know that is retinopathy of prematurity. And then we have a battery of speakers, Meenakshi, who is very, passionate about teaching. And we have Santosh, who is very possessive about teaching. And then we have Vivek. Vivek is also very, Vivek is also very, enthusiastic about teaching and, with the medical education. And the two guys, Satansu and Deepak, they are very enthusiastic and very energetic, in organizing such meetings. And this is very important, kind of session where the stalwarts in ophthalmology will deliver the lecture. What we are going to discuss in this particular session is, something about the theory. When you go to the examination, then what are the things which are important in the theory? How do you write? What is the type of questions? You have anatomy, physiology. You have the diagnosis. You have the the differential diagnosis, and you have the management. So all these aspects, they are very important when we are discussing the theory. And especially, if you are, writing about some particular disease, maybe you may get an essay type of question where you have to write about the, the clinical features, the etiology, and the examination. What examinations you do, and then how do you arrive at diagnosis, and so on and so forth. And when you are going for a oral examination or a practical examination, what we call, then we have, various, areas are there. Like, you go for the long cases, and long cases, you may get a long case in a one particular, ophthalmic disease. Then you have short cases. The short cases are there. You have the instruments are there. The questions are mainly asked on the instruments. And also you have, face-to-face with the examiner. When you are facing the examiner, what questions they are asking. I can only tell you a very simple thing. And that is the questions which are either put in the theory, or the questions which are kept for the practical or the viva examination. They are all questions which you daily discuss. There is nothing out of blue. There is nothing which you don't know, or there is nothing which you have not practiced during your residency program. So you don't have to be tense. Don't be tense. Do your normal work. Don't get overstressed. What people do, they get overstressed and they, read too much, like especially when they are going for theory examination. They read too many things, and then ultimately when they go to examination hall, they get confused and they get, perturbed and all that. So that is not the point at all. When you go to the theory examination hall, go with a free mind. Before the night, when you go for the when you are going for the theory exam, just don't read anything. One night, don't read anything. Have a nice sleep. Go to the examination hall. Appear in examination hall. Write. Come back. And then when you are going for an oral and practical examination, keep yourself absolutely free. Just think what you have done when you were going for the rounds. When you go for the rounds, you discuss each and every case. Each and every case about the clinical feature, what is the presentation, how did you examine, how did you arrive at the diagnosis, and what all you supposed to know about that particular case. And then, you are the only one who are there for the management. The first line of warrior, COVID is there. The first line of warrior, who is the first line of warrior? The first line of warrior are the junior residents. The junior residents, what type of case is this and how you have to deal. And then the senior residents are there, who are basically the guides. And the consultants like us, we are there to help you to arrive at some conclusion. And then, if you are at some, difficulty, we try to solve your problem. And then you can institute the treatment. And of course, you will see what the result is. So you don't have to go to anywhere. You don't have to read too much. You have to make up your mind, organize yourself, keep your mind fresh, and then go for the examination. This is my suggestions to all of you. And of course, there is a battery of speakers here. So I would, like that, you hear their presentation. They are all stalwarts. They are all great teachers. And they have been, teaching in their institutions for a very long time. I hope that this session will be a great and a big session. And I have something in my mind, which I will tell you not now, maybe later, sometime later. Thank you, Satanshu. Thank you, Deepak. And thank you all. And thank you, especially the ENTOD, for organizing this meeting. Thank you very much. And you can go ahead with the presentation. Thank you very much.
Thank you, Ajaz sir, for speaking from heart. I know that students come in front of teachers start speaking from the heart. And unlimited time you can speak for the students. So, Dr. Saloni?
Yes, sir.
So, we invite Dr. Khurana.
Now, I would like to request my fellow special invitee, Dr. Akansha, to take over. Dr. Akansha?
Thank you, Dr. Saloni. I hope I'm audible to everyone.
Yeah.
Okay. Good evening, everyone. I am Dr. Akansha, resident in KGMC, and I would welcome you all in this webinar. We all know that exams are a part of getting through university. Unfortunately, exams can trigger stress and a lot of anxiety for many students. So today we have a galaxy of speakers here who will be giving us insight about postgraduate examination and scientific writing. Without much ado, I would like to invite Dr. A.K. Khurana sir to enlighten us about a very important topic, that is how to prepare and fare in PG examination and overview. Over to you, sir.
Good evening, everyone. Am I audible?
Evening, sir. Yes, sir.
Audible, sir. Share the screen.
Okay. Sorry, sir. So, good evening, everyone. Good evening, Dr. Azad, Dr. Gra, Dr. Sitanshu, Dr. Deepak Mishra. So, first of all, I congratulate the PG Forum for organizing such a webinar, and I convey my personal thanks for giving me a chance to share my views slides on how to prepare and fare in the PG examinations. So I think by now, mostly PGs, they have appeared in so many examinations and they must know how to appear and fare in the examination. However,
Sir, share the screen. Dr. Khurana,
It
share
is not share.
slide share.
Okay, just
Share the screen.
share. यहाँ से share.
If you have a slide, then share the screen. Or you can speak from your heart. Yes.
Is it okay?
Okay, sir. Okay.
So I shall be sharing my views on how to prepare and fare in PG examinations. So in fact, what I personally feel that our residents need to know how to fare in residency during these 3 years, because these are the 3 most important years of their training and their life, through which they will do well throughout their life. So the aim during residency should be to acquire good knowledge of the subject, learn and master the diagnostic and management skills, and be conversant with the digital technology. And with this knowledge, they should be able to reproduce in the examinations. And not only this, they should be able to become a competent clinician, academician, and a researcher in their life. So what I want to say that this is just a lifestyle of the residents, which I am going to tell them, not any academic discussions. So even before joining the residency, they need to gear up. That is, when their results are finalized that they are going to be an ophthalmologist going to join residency, they need to gear up there and then. It is important to have a good head start in the residency, because first impression is the last impression. So one should go through the basic ophthalmology books even before joining, and start watching YouTube videos for various examination and investigative techniques which they are soon to perform. So as a resident, it is very important to looks. A well-groomed resident is always stands apart, and he needs to be polite with other staff. One can learn many things academically as well as ethically from this staff. So this is a well-groomed resident. We want him to be well-trimmed with haircuts, clean shaved, warm smile, and confident with formal dress, and firmly handsome. So some basic rules to start studies during residency, that you start with the basic books. So any resident who is through with anatomy and physiology always have an edge over others. Then case scenes in the OPD. Each case should be thoroughly studied on day basis and then can be discussed with the seniors. Then basic examination skills, one should learn slit lamp examination, direct and indirect ophthalmoscopy, and other things as quickly as possible. And one resident should be proactive to attending the emergencies, because emergencies can provide perfect one-to-one learning from your seniors. So then a resident must know how to extract knowledge from the immediate seniors, which are the main source of the knowledge for them. So they need to create a good rapport with seniors. They can be your guide throughout life, not only for these 3 years. Then the resident should be inquisitive. They should not hesitate to ask any questions, because inquisitiveness leads to questions, and questions lead to answers, and answer leads to a broader perspective in life. So be proactive, prepare a new topic daily, and discuss with your seniors and get practical tips from their experience. Then the resident should join ophthalmological societies and teaching programs as early in the ophthalmic world, and they should join and attend various PG teaching programs to update their knowledge. They should join the surgical skill transfer courses, because these provide a virtual hand of training to them. They must attend conferences and write articles from the very beginning. They can create their own identity in conferences from the very beginning. They can start making paper and poster presentations in the conferences. It will provide them an added confidence and recognition. They should be active in writing original articles and case reports. Dr. Hanawar is there today with us to tell them the art of this writing. Then if they follow the knowledge will automatically follow them. Then coming on to how to prepare for the examinations. The preparation of the examination basically is a continuous process throughout the residency. The art cannot be learned only at the 11th hour. So it is 3 years work which will help them. they need to have a structured plan for study throughout the residency. Ideally, it should be an integral part of the curriculum. Certain tips for continuous process of learning are: they must set your goals, determine your priorities, plan yourself to follow the goals, change your habits accordingly. Hard work during residency is the key to success in life. Then we need to overcome certain personal weaknesses which become a big obstacle in fulfilling our dreams. And some of these common weaknesses of us include lack of goal setting, lack of self-discipline, over-socialization, lack of proper prioritization, procrastination, poor communication and writing skill, and last but not the least, the lack of planning. Planning is the most important for every activity in life, and those who fail to plan are surely planning to fail. Make a plan for effective study during this period and learn how to attempt the theory papers. I think Professor Mangadogra is going to give them tips. Then they should learn how to perform well in the practical examination, and Dr. Meenakshi will give the practical tips for this. Then for effective study, understanding is the key factor. So always aim for understanding the subject rather than cramming. Promote understanding by rearranging the material and linking it with the clinical aspects which you have observed and practically performed during your residency training. And write and revise the important points frequently. Then what to study near examination? Then questions from the last 10-year theory papers should be prepared thoroughly. They should develop a plan for attempting these questions by referring to the sample answers. Plan for attempting the question should include important key points to be covered, flowcharts, illustrations, etc. Then maintaining your motivation during exam days is most important. So always think positive along with the hard work, have self-confidence and never underestimate yourself. Have good friend circle for group study as well as to boost up your mood when you are in under mood. Then meditation and yoga sessions are also useful to tide over the examination stress. The key to success is to focus on goals and not on your obstacles. Undoubtedly, one should balance the work with play, so they take frequent breaks during the study sessions. As we all know, the all work and no play makes Jack a dull boy. Then time management has its own role. A good time management is essential both for theory as well as practical examinations. And in general, the time management is key to success, not only for examinations, but for every sphere of life. So to conclude, I will like to say that learning in medical sciences is a continuous process, and so is the preparation for the examination. But I will tell to residents that it is very easy to pass examinations, so they need not worry. Rather, it is difficult for the examiner to fail the candidates unless and until the exam candidate is bent upon. Then we all know the eyes see what the mind knows, and the mind knows to what it is exposed. So regular study, observation and hands-on practical work are the key ingredients to learn this science and art of medical practice. What we have discussed are just broad outlines. However, each one of the residents have their own talent and own effective methods to study and perform well in the examination. Hope these simple tips and suggestions should give you some added confidence to fare well in the examinations. So take home message: the goal of residency training should not only to clear your exam, pass the examination, but to acquire good knowledge, skills, and attitude to a level appropriate to fare very well in the examination, and after that, practice independently as a competent general ophthalmologist. So, best of luck to all the examinees, and thank you very much for your patient hearing.
Dr. Khurana, sir, thanks a lot for this talk, which is,
Yes,
you have touched very relevant point, not only about the theory and practical, but you have developed the personality of the student during the exams. And that is very important, that during the exam, you should have confidence and you should not lose your personality, whatever you have. So, moderator, we are going to sign next speaker.
Thank you, sir. That was very informative and interesting presentation. Now, many of us have faced a situation where we have the knowledge about the topic, but are not able to pen it down on a paper properly. So, on this note, I would like to invite our next speaker, Dr. Mangat Ram Dogra, sir, for giving us some tips for theory examination. Over to you, sir.
At the outset, I would like to thank Dr. Satanshu Mathur and Dr. Deepak for giving me this opportunity to interact with you. I think that is what I did lifelong. So are probably Professor Azad and Dr. Khurana here. I think we spent almost entire life doing this. But one of the, sorry, I think. I think the topic which I got is, I think it's a difficult topic. I can hardly really tell you something which is going to be of a great help, but I'll try giving few practical tips as well as talk to you about the experiences which may be of interest to you. And so basically, I think what is very important and we must understand, all of you must go through the curriculum in ophthalmology. And this curriculum in ophthalmology is available once you go to, it's already on the MCI, this thing, websites, and you have all these 7 things there mentioned right in the curriculum, right from the basic medical sciences to clinical ophthalmology, refraction, ophthalmic super specialty, like you get posted through various clinics once you are there. And these basic sciences like ophthalmic pathology, microbiology, biochemical sciences, and also a community ophthalmology and research. A part of that research, you also have a thesis, as well as Dr. Khurana was telling, that you kind of get into that mode right in the beginning, and so that you can sort of write some case reports or other things. And then what about the course content? Basically, the course contents, if you look at the website, there is, you have basic sciences. What Dr. Khurana already mentioned, you start with the anatomy, physiology, you have biochemistry, you may have pharmacology, and you may have so many other biochemical sciences these days. And optics in ophthalmology forms a huge part. This one not only includes refraction, but you use so many optical devices which you depend. So that's why it's so important. And of course, clinical ophthalmology goes all across, starting right from front, going to the back, and even up to the neuro-ophthalmology. So basically, as far as the teaching in theory is concerned, I think in the olden time, it was a ritual to have very specific theory lectures, which over a period of time is changing. And the lectures are still there. I think they are relevant. They may be very important as far as the basic lectures on some of the aspects are concerned. Then the demonstrations they are very, very essential, because I think there are so many situations, especially all these investigative techniques where we have to learn that it's only by demonstration. Then the seminars are somehow, I think, these days going down. And that's where probably the theory would be learned a lot. And also in symposia, in bigger hospital, like from where like I was, Dr. Khurana, and of course Professor Azad from All India Institute, intra-departmental meetings. These are very important. I think we have interaction right from not only with the basic scientists like a pathologist, microbiologist coming in, as well as also pediatrician, radiologist. I think they take up, and you have that kind of interaction happening. And journal club is very, very important aspect to learn theory, because that's where you're going to learn the recent what is happening. And participation in any of the CME programs or any of the conferences, that gives a lot of teaching to everyone. I think this theory exam has usually 4 papers. And these 4 papers, they vary. I've seen the way they are mentioned. They could be one for basic science, another for clinical ophthalmology, maybe ophthalmic surgery and related topics or research advances. But at other places, they may be a little bit different. And they are not really very much that it will be a category that if you have one paper, the topic from other will not come. No, you will get topics from others also. They could be mix and match. So that you must always remember, as well as there may be some certain changes institutional wise, or sometimes it may be a little different, but usually 4 theory papers are there for everybody, and that is what one has to clear. Now, how to prepare for theory exam? That's where the major thing is. I think books are essential for all residents. These days, somehow, they may not believe much in books, but believe in books. We have Khurana here, who has written the best of books. I think if you follow his book, you're never going to fail. And that's what. And use fewer and selected books. If you are going to learn from Dr. Khurana's book or from a Yenov, you follow that book. Don't jump to many books. And that book should be followed very thoroughly, right from beginning till end. That is what is very important. And I think we are all trained in reading books. This is a training we receive. So don't follow the same practice. Don't forget that we have to kind of change something. Dr. Khurana already said that we have to start with the basic first. Basics are very important. If you know the anatomy, physiology, the basics of the optics, and basics of refraction, and so many things, even basic investigative techniques, I think your job would become much easier. You would enjoy reading more, as well as you would remember things more. So you need to have a regular daily routine of studies. Having a practical approach in ophthalmology, which Dr. Khurana also mentioned, is most important. Don't cram the subject. It's not going to work. I think if you have a practical approach, what you see and you practice, that is what is going to be very, very important. And your peer group that matches you is the best company. I think they will always help you, as well as they'll keep you motivated for reading, for doing things in life. And I think peer is the most important at any stage, right from childhood also. So you need to study smartly, not only what Dr. Khurana said, that you should be smartly dressed, but also you should know what is more important than others, as well as at the same time, don't leave out anything. If you leave, then it's a problem. And always have a schedule for completing your entire course. Start from beginning, as I said in the beginning, and we always tend to give more time to practical and neglect theory paper. This is a big mistake. That's how many people suffer, especially when I'll come to later on, especially in DNB. Sometimes they take so long that they may not, and even in some places now, what has started happening even in medical colleges, that they started sending papers somewhere else for checking, not with the examiner, those who are conducting your exam that time. So everyday reading for the cases seen in the ward and OPD, already emphasized by Dr. Khurana, I think that is very, very important. If we're going to read about what we have seen and everything about that, and especially the aspects which we are, then you can correlate that and you'll never forget. In addition, read one chapter every day, make a habit. So if you read one chapter every day, you will have the whole thing done. And you need to read all chapters. I mentioned that in the beginning. And last 2 months should be for revision. Don't leave the entire book for last 2 months. Then it's going to be a problem. I think definitely, I think this part also, Dr. Khurana said, 10 years paper. Solve the previous year's exam papers for many years, as many as you can get. You will find that minimum 30 to 40% questions are repeated, because these are important topics. They are bound to be repeated because we want to examine you on common things which are day-to-day problems. So that's how it helps also. Remember, there are no shortcuts. As I already mentioned to you, you need to follow a particular book, go right from beginning till end, and don't keep on switching from one book to another. You will have a problem. You will get totally confused. You will do more harm. And you need to jot down or underline or highlight the key points for revision. It's very important sometimes. If you have done that, you can quickly revise. Otherwise, you will have to go through each and everything and focus on weak areas. Why I mentioned optics and refraction, because this is all neglected by everybody, and then we don't understand. Refraction still forms the major chunk of the practice of ophthalmic ophthalmology, and so are the optics. You see, most of the equipment which we use has got optics, and you need to kind of go through that very, very carefully. And standard prescribed books are the most important reading material. Remember that. If you read the book, that is going to be more helpful rather than present generation only going to Google. They're just going to Google the whatever the topic, and they want to look at that. You won't get entire information the way you would like to have it, right from the basic all the way to what is happening now. That is from the book. And journals and review articles, of course, they do help. And there are problems at this time. I have seen this myself, and I get very worried because we being mostly educationists, there is a lack of dedicated, inspiring, and well-informed teachers in many peripheral colleges. And it's not their fault, because they are now sort of getting outdated because they don't get updated. There are many places they don't have a FACO. There are many places they don't even know how to do examinations with indirect ophthalmoscopy. I'm a retina person. I go to many medical colleges. So they have never done that. So what I mean to say is there is a lack of practical skills and knowledge in various centers. For that, we need to create a situation, more resource center, as well as professional development programs, so that we can have all of them trained. I have even gone to places for a sort of doing an inspection or a survey where teachers feel very sorry that they have not seen many of the things, or they don't know many things which are very important these days. And there are, of course, issues with the resident also. Resident is exposed to so much of information. They are not only confused, they also want everything to be done, which is not possible. You see, in our country, there's a resource constraint. So focused motivation may be lacking. They may be interested in something which, in fact, may not be of importance. That is where the problem lies. I think if they go back to the basics and then study everything, and after that they go into, then that is what is very important. And shortcuts are applied most of the time. They may be just interested, I just want to do cataract surgery and I'll be fine. They'll not even look at, they don't even know that what are the complications, what are the consequences, how to manage. So shortcuts are not. And that is what the problem is also at this time, which we need to sort of take out. And time management is very important. It is highly this thing that we should be organized and disciplined, and ensure you take out enough time for preparation, revision, as well as relaxation. I think this part, relaxation, Professor Khurana also mentioned, because that is also very, very important aspect. In addition, have time for clearing your doubts with your core group. Your seniors, he mentioned about senior residents, he mentioned about the faculty, immediate seniors. You see, you learn so much from everybody. If you have that kind of a group which is vibrant, you're going to be learning much more. There are little differences between DNB as well as MDMS, and I'm sure both kind of residents are there. DNB students may be better exposed to latest equipment and practices than MDMS, because many of the colleges in the setup, maybe in the peripheral medical college, they don't have everything available, but they have certain advantages. They have structured teaching program. They have those trained teachers, which in fact impart good education to them, although they may not have all the equipment. And proper faculty may not be sometime available for DMB students. They might have more people, those who are more interested in doing surgery, or may not be having teaching experience at all. That can happen. And teaching and training for both varies according to the place and institution. So we have institution. In fact, I think that we've been DNB examiner me for many years, up north, south, everywhere. Then we understand if they come from very good institutions, and I don't need name them. I think myself, I have seen 100% result. Although it never happens, I have written here 40 to 60%, and in some subjects it is still about 15, 30%. So it is possible, because I think good institutions would totally be different. So DNB is a problem in a way that theory is given much more weightage. Like why I mentioned here, you have to have 100 each paper, 100 marks each paper, and you get 200, and in practical only 300 marks are given for that, which doesn't happen in MDMS. That is different there. You may have mostly more weightage for practical as compared to theory, or sometimes it is 50-50, that is variable. So the DNB entry may be easy, but exit is a problem. That's where the issue sometimes happens. And MD is the other way around. I think the entry may be difficult, MDMS, but exit is relatively easy because the exam is held only at that place, and in DNB you go to a different center. So what are the tips to crack exam? You need to scan the question paper very carefully, read each question, and think how much time for each question is required. This is very important. If you don't have a time frame in mind, it's going to be a problem. Whether you need for some kind of a shorter notes, just about say 5 minutes, 7 minutes, 10 or 15, mostly like we have 10 questions. Or you may have sometimes bigger questions and small notes. So you must have that time frame and make a list of things asked in the question. Sometimes there are 3 things asked and you divide those marks, suppose it is 10 marks, and you keep on spending only on etiopathogenesis so much of time, and that is hardly 2 or 3 marks. That doesn't work. And select and attempt easy question first. That I feel is important, because that builds your confidence. And first solve the question with more marks. If the question has more marks, you tend to solve that and divide that, as I said, different areas in that. And you must attempt these questions quickly because you know them, and that will build the confidence. And this approach, according to me, may be better than going just in an order, because sometimes you get into a situation where a difficult question is there, you are not knowing, then you waste time, and then it's a problem. And you need to definitely attempt most of the questions. That's very, very important. Or all questions. I think I need to emphasize this point. Always make a neat diagram wherever possible. There are many. In anatomy, you may get development of a lens. You may get blood supply of optic nerve, superior orbital fissure. Just make a diagram, label it, you are done, and you'll get full mark. And same way, you may have optics of indirect ophthalmoscopy. If you just make a nice diagram, you are done. That is what is very important. And label it nicely. The flow charts wherever possible. Flow charts are very important. That give the gist as we manage particular condition and enumerate points. There are so many, like if you are talking about complications or you are talking of various therapy, you can enumerate them very boldly, 1, 2, 3, 4, 5, 6. That is, nobody is reading line by line. That is what is important. But if there are these points which are highlighted, underlined, or clearly written, or diagrams are there, you're going to definitely not only pass, but pass with flying colors. Like, I'll give you some example. Posterior polar cataract, if it comes to you in the exam, what do? So what are the important aspects here? Isn't it? If you don't know about that, why the posterior polar cataract occurs and what is the complication, I think that is going to be the crux of problem. Same with post-op endophthalmitis, which is so common. If you are not knowing that what you're going to immediately do in such a situation, and if you don't write that, it's not going to work. Diabetic macular edema. This may be asked every time. There will be a question on diabetes all the time. May not macular edema being the commonest thing. Now, you have to know very thoroughly and also write the salient points about diabetic macular edema. These days, I put up just a OCT angiography here or a OCT maximum number. Everybody is carrying this. So you need to learn about these things. My favorite subject, retinopathy of prematurity. You may be asked just classification of retinopathy of prematurity. You need to make a neat diagram, label it, and put those stages. Or you may be asked management of a retinopathy of prematurity. So you see, these things you can answer very well if you are clear in your mind and you are to the point. Same way, here's a gas put in a retinal detachment case. You may be just asked about sulfur hexafluoride gas. So, I mean, you should know about it, that how much this expands, what is expansile and non-expansile, and where you use it. So that kind of a thing should be there. So in the end, I would like to just finish my talk here that how to attempt the theory paper is, as I said, you must attempt all the questions after you have gone through each question very carefully. Avoid long answers. Be to the point and attempt it in a concise form. I already said, if you can make diagram, enumerate the points and highlight them, and all aspects need to be brought out. Depends upon, I told you, divide. The question may have 4 components. In the description sometime, it is a long question. Then you need to divide, because each thing may have just 2 or 3 points, numbers giving you. And the salient and the most important aspect should never be missed. Always, as I said, I've said that if you don't write the complication in a posterior polar cataract, that why and how much you have a posterior capsular rupture and how you prevent it, I think it's not going to get marks. So thank you, friends. And I hope it will help you a little bit somewhere, but it's a difficult topic and say something in a theory, which is always a tricky situation. Thank you very much.
Thank you, sir. Thank you.
Dr. Dogra sir, you have made this difficult topic very easy to understand. You have very right. That's the crucial point. The teachers are very intelligent. By just seeing your 2 or 3 lines, they know your knowledge status. Don't try to make a fool of the teacher. If you made a diagram, if you enumerate diagram, if you made the flow chart, teacher knows that you have the complete knowledge of the subject. So this is very important thing. So you have done justice to your part, sir. They are respecting it and more than this. And second thing, way of your talking, way of your teaching, we put the confidence in our students. Deepak.
Thank you. Thank you. Thank you.
Thank you, sir. I'm sure residents will benefit from the methods you suggested. So if theory exams make us shiver, then practical exams almost give us a nightmare. For students like us, we suffer from verbal blackouts in Viva exam. So on this note, I would like to invite our next speaker, Dr. Meenakshi Swaminathan ma'am, who will be talking about some practical pearls for the practical exam. Over to you, ma'am.
Thank you so much. And thank you, Sanshu. Thank you, Dr. Deepak. I feel very honored to be here in the company of esteemed teachers and friends. I trained at PGI, so I feel very special to share the stage with Dr. Mangat. Originally I was told this is about 30 minutes, but it was clarified that it's a little less. So I request the moderator to ask me to wind up if I seem to be overshooting the time. So how I have designed this, let me tell you. I have experience being a DNB examiner and a DO examiner. We have just got MS from in Shankarayatralaya, but I have been through an MS course. So I know where typically people get stuck. And I have had PGs come out and say, oh, I wish I had prepared better. So I'm just going to take you through a mock practical exam. So this is you, students out there. Hello. Now this is you entering for your practical exam. Okay, so here we go. So yes, practice makes perfect. And I saw this lovely thing which says there are 5 study hacks, but in which I will point out that one of my favorite way in preparing for answering, especially if you're a shy person, is to say it aloud. When you say something aloud, you hear it also, and it reinforces things. Reward yourself. Why not? If you've finished a particularly tough chapter, get yourself a bar of chocolate. And teach to be taught. It's my favorite thing. So if you form little study groups for preparing for a exam, for the practical exam especially, one becomes a mock examiner and the other becomes the student. And so you start asking questions. So teach to be taught again is I think a great tool. Now, let me start off at the outset by sharing resources. And this is the list that I took from students who have attempted the exam, who have passed the exam. And they told me Arvind book of FAQs, Dr. Namrata Sharma's book of cases, website mrcoft.com, particularly Chua's pages, review of ophthalmology. And of course, here we have esteemed Dr. Khurana's books, which are extremely comprehensive, particularly the refraction book, and the AAO preferred practice pattern, which are PDFs available for free. These should be a good list for you to prepare specifically for the practical exam. So without delay, let's start off with clinical cases. Now, sometimes you will get one long case, one short case, one fundus case, and one refraction. In some exams, in like DNB, it is 3 20-minute cases, anterior segment, posterior segment, and a mixed bag, and a refraction case. So sometimes the format varies from every year to year, and whether you're an MS or a DNB course. So if I were you, I would be prepared for long case, but quickly summarize in a short case. And if you're asked to say, doctor, give me the diagnosis, then you should be able to say that in one line as well. Okay, by the time the afternoon rolls around, the examiners are tired. And so they may just say, okay, tell me what, summarize your findings. So you should be able to quickly summarize things without feeling like you're stumbling. So, I'm presenting a case of anterior segment mixed bag. Maybe you have the history is a 75-year-old engineer, presence with progressive drooping of eyelids since 2 years, and what could be the causes and what are the history would you ask? Maybe the questions that you'll be asked. So the first thing I'm going to say is do not commit to a number, and let me tell you what I mean by this. Here is a patient, and you know that you're going to need to ask certain questions and tell certain findings. If they ask you what could be the causes, don't say the causes of ptosis at this age are 5, and then you're stuck after 3. So never commit to a number, just start enumerating from the commonest. Pearl number 2, don't beat around the bush. For example, when I showed this in a mock viva the other day to my students, I said, can you describe? He says, there is no abnormal head posture, there is no facial asymmetry. Where can you really see all this in this picture? You can't even see. So don't beat around the bush, but be systematic. In the sense, if in a patient with ptosis, you have to mention the pupils, you have to talk about the EOMs. So you make sure all those are systematically presented. For example, in this case, you're going to have to say lid crease, MRD 1 and 2, LPS action, lag of thalamus, Bell's phenomenon, extraocular motility, pupils. I'm going to wait and see whether you're going to talk about the Cogan's lid twitch sign, whether you're thinking of myasthenia as cause of an acquired ptosis. As an examiner, will be waiting for it. So pearl number 3, be ready for lateral thinking. And what I mean by that is, your examiner, as for describing the case of ptosis, may suddenly jump and say, what is the relationship between ptosis and ocular motility? And taking you in the direction of a third nerve. Maybe, and so they'll say, what is the relationship between ptosis and pupils? Taking you in the direction of Horner's syndrome. And then maybe the whole thing will move into the realm of neuro-ophthalmology, and they'll start asking you to trace the Horner's sympathetic pathway. So you never know when the exam will be, where will it be going. So be ready for lateral thinking. Now moving on to a fundus case, most important thing is to be systematic. So as you know, you start, as you would do in your ward rounds, you start about talking about the media, then the disc description, and then the vessels, and then the posterior pole, and what you see outside the arcades. And then sometimes you're not sure. So and what happens is there's sometimes a long gap between theory and practical. So and by the time you've actually even finished your course, so important to practice with an atlas and rehearse with a friend, especially for fundus cases. Open a fundus atlas and start talking about what you're seeing in front of you, case after case after case, and ask your friend to quiz you. The pearl number 5 is, if you have seen this case, you're not sure what it is, you've just blanked out, offer a differential diagnosis. Tell them, tell the examiner, may I say a differential diagnosis? And no examiner is going to say no. He's going to say, okay, go ahead. What is the probable cause? Then you can say, I see subretinal exudation. And then you can come up with 1 or 2, 3 causes of subretinal exudation. You may miss the courts, as a bang diagnosis, but it's okay. Sometimes you're nervous in the exam. Sometimes it may be little atypical. It's good to go with a differential diagnosis. That way the examiner knows that you know how to put things together, how to think. So number 6 is practice the anterior segment case with a color-coded drawing. Practice drawing fundus with an Amsler's chart with a color code. It is, if you get a retina person as an examiner and you draw there with a tiny little bangle, one tiny circle, and you're trying to show all your findings in that, they're not going to be happy. Sometimes they will just hand you the Amsler's chart and see whether you know even how to place the chart. If you place the chart correctly, the examiner will immediately know that you know what you're doing. So if you can, practice drawing with Amsler's chart. For example, they may suddenly throw something at you which says, okay, what is the Shields classification of Coats disease? I had to put this in there because Honover is the co-author. Anyway, jokes apart. So they may just throw something at you and you may be caught off guard. And so the pearl there, I don't know why the pearl didn't come. The pearl there is, of course, if you don't know, say you don't know. Okay? So don't try to guess. These are all very clear classifications. Just say, I don't know, and then usually they will move on to the next topic. Refraction. When you move to refraction, you will usually always be asked optical cross. Remember drug correction. You may be asked all about the cycloplegics. Contact lenses and optics of instruments actually comes under refraction. So please know them, prepare them well for the refraction station. It may be something as simple as, can you do transposition of the following? It may be an examiner is tired by afternoon, he's taken your paper, he's looked at your refraction value, he knows you're right, but, or maybe somebody whispered it in your ear, I don't know. So he will push something under and say, can you do transposition? And why is it important, doctor? And there, the refraction station went very well. Now we're going to go to the table viva, okay? Now I'm going to cover really every aspect of table viva very quickly. So again, preparation is the key. And this is not preparation between your theory and the practicals or 1 week before the practical. This is preparation throughout your course. If you have been a diligent student and have looked at instruments, drugs, and investigations throughout your course, remember this is usually a breeze. So in recent advances section, you may be asked something as, what are recent advances in the treatment of capillary hemangioma in an infant in the last 5 years? Straightforward answer, but they may catch you by saying, what is the dosage? Or it may be as recent as Jan 2020, what is the optic trial that was published? So the pearl here is that, where do you read recent advances from? Good source is IJO, the DOS journal, the state society journals also very often have very good recent advances, write-ups. The AIOS proceedings, believe it or not, is a great resource. It has excellent videos from every session of the AIOS, of which recent advances, in fact, it's going on. Recent advances in glaucoma is currently being sent to us by Dr. Arup. So community ophthalmology. It may be as simple as classification of vitamin A deficiency, a piece of cake, or it may be something like an NGO wants you to conduct a surgical camp in their village. How will you go about it? Maybe they're trying to trick you. They want you to know what are the rules. So if you don't know, like I said, say so and move on. So moving on to there is one segment called basic science. Again, it may be something like describe attachments of the orbital septum, but be prepared to draw. They might just shove a paper in front of you and say, go ahead and draw it, doctor. So don't think drawing is over with theory paper. It may feature in practicals also. Surgical instruments. First, very often either they will hand you one or they will ask you to pick one. Okay. So in your mind, be prepared which instrument you would pick, either in the oculoplastic tray or from the anterior segment tray, typically. Thankfully, they don't keep many VR instruments. And strabismus is anyway only a muzzle hook, so it's okay. So you have to first identify, use the proper noun. You say this is Kerrison's bone punch or bone wrongure or whatever you want to say. And following that, usually you are asked a question in relation to that. Like, for example, it will be compare and contrast endonasal with external DCR, maybe the question that will follow this. So the pearl here is, generally don't contradict the examiner with vehemence. The examiner may say different from you, but usually be respectful and just say what you have to say and keep quiet. Don't get into an argument. Drugs typically, again, usually are very straightforward. You have to know the pharmacological name, percentage dilution, route, dose, mechanism of action, indication, contraindications, side effects. You have to know this for every drug that you encounter in ophthalmology. And the best way is throughout your PG, just rehearse it quickly. Moving on to radiology. Radiology, I put radiology here, but this is true of all investigations. So you may be shown a plate like this, or you may be shown an image on a laptop. Don't start talking immediately is the pearl. First, spend a few seconds looking at the image, studying it systematically, and then start talking. For example, we did a mock viva the other day, and I said, go ahead, tell me what's going on here. And one of the people I was doing the mock viva with, you know what that person said? I think there is a bony, expansion of the zygomatic bone. I think there is maybe a bony tumor. This person completely missed the flow fracture. Now that is a serious, serious mistake. So the trick here is be systematic in your description. If you have trained yourself to be systematic, like talking, say, I think this is a CT scan, coronal cut at the level of, mid-level of the orbit, I can still see the globe. Patient is slightly tilted because the eyeballs are a different size. And then if you go systematically, you won't make silly mistakes. So very important to read any scan, investigation, OCT, whatever it may be, systematically. Next, you will be asked OPD instruments. It's not uncommon, maybe something like this. You may be asked even the variants. You may be asked, where will you position this, etc., etc. Microbiology. What you have to do is describe the stain, or identify the organism. You have to know about the media for culture, the infection that it causes in the eye, other organisms in the class. Like, for example, I asked the other day, so what are the other gram-negative bacilli? And there was a complete blank. Please at least say Pseudomonas, okay? And you have to know antibiotic susceptibility of all this. Come on, I mean, eye infections are so few, really. You have to at least know them really well. Pathology. First, identify the tissue. Again, there is no shortcut for this. You have to look at ocular pathology, atlases. See, when I was a student, that's all you had. You had a few textbooks. You have so much resource on the internet. For a basal cell carcinoma, there are 25, 30 images out there of every type, for morphium, whatever it is. So please use that. And you again have to do a systematic description and make sure you say the important findings, like, it is not complete unless you say peripheral palissading in this case. And important, the other day I showed this again to a student, and he said that it starts off by saying there is a big vacuole. And I said, God, how am I going to help them? So beware of artifacts as well. So again, be systematic. And I said, practice with an atlas. Ward rounds. Ward rounds may be an actual patient, or it may be an image. If they're not covered ground in other segments, they will use the ward rounds for this. They may, show you something like this and lead you on to trials. So know your trials. And the best way to know the trials is to quiz each other. Surgical techniques. When they come to surgical techniques, the examiner may show a diagram, or may play a video, or it may just be questions like, example, what are the choices of surgery in congenital ptosis? Describe the steps of the LPS resection, because they want to know whether you have actually even seen these surgeries. Now, if you look, the pearl here is look at the number of webinars that we have had, a plethora, a bouquet of webinars. There are so many YouTube videos, wonderful videos. I know Dr. Santosh's videos are there, up there, wonderful videos. AIOS proceeding videos are there. So please go through surgical videos. I never saw this during my PG. I never saw this procedure is not an excuse when you have so many resources out there. So I think I've given you a bouquet of pearls here. I mean, I've given you a pearl garland, a necklace of pearls. And I think if you follow some of these tips, you are going to just ace the exam. But there are no shortcuts, no quick fixes, no blaming others, no I'll do it tomorrow, really no excuses. I want to introduce snippets. Dr. Deepak Mishra has been kind to share this in the Facebook page. This is available on Spotify and Google Podcasts. This is a podcast initiative from Shankar Netralaya. It comes once a week. It's only 10 minutes. You can listen to it on the go when you're doing your walk. We have covered COVID for ophthalmologists, congenital cataract surgeries, keratoconus, and digital eye strain. And this next episode, I've covered on how to ace PG exams. And the next one is going to be on, history of ophthalmology, very cute snippets. So I look forward to your listening and giving your feedback and making use of it. With that, I thank you once again. Happy to help any of you. Please write to me at drms@sma.org. Thank you once again for this opportunity. Best wishes.
Thank you, ma'am. Thank you for the thought-provoking tips. As much as conquering our exams are important, so is overall molding of our career as a budding ophthalmologist, in which writing and publishing an article forms a major role, for which who can tell us better than someone who is himself an editor of the most esteemed journal of our country. Hence, I would like to invite Dr. Santosh Hunawar sir, who is going to deliver a talk on manuscript cycle at IGO, What an Author Must Know. Over to you, sir.
Thank you so much. In the next 15 minutes or so, I'd like to cover what happens behind the scenes after you submit a manuscript to IGO for that matter, any journal for that matter. Journal processes nearly remain the same. But before we go forward, why should you publish at all? What business does a resident have to publish? Publication is mainly for the faculty. That's what we think. But publication is extremely important for a resident for several reasons. One of which is that a selfish reason is that your CV becomes stronger. These days, you don't stop at residency and you really want to progress on to do fellowship, Indian or international. And if two people are exactly similar in terms of, say, a fellowship exam scores or you have fared equally well in the interview, the differentiator between two equally well-poised individuals otherwise is a publication. So one publication can tip the balance in your favor if you have it. And if you don't have it, the person who has it will get the advantage. That is one. Second is that if you want to apply for an international fellowship, or even if you want to apply for an ICO fellowship, which is a funded 3-month international fellowship, if your CV is strong and it has a few publications sprinkled somewhere, then it's always a good, you get an advantage. So that's a fair advantage. The third important reason is that during residency, you see a lot of good cases. And if you have a documentation, if you have a mindset to document every good case that you see and write it up, then that is actually a very good thing because that helps you in your studies as well. You become very systematic that way. And one of these cases that you have documented might become published. And in fact, if you have a grand round in your own medical college, and if you have a very beautiful case that is presented in the grand round by you, then you might as well write it up. Even if it doesn't get published in a major journal, it may see light in a national or a state journal. So it's always a good idea to write up things. So this is the editorial process that happens. Whenever somebody submits a manuscript online, it goes for an editorial review, then goes for production, and then goes for publication. So this is the first part of the editorial review, where there is something called a quality check. So when a manuscript is submitted, editors and their team examine the manuscript. They see it very much in detail, look at the language, look at the formatting, look at whether the manuscript is complete or not. Is it missing an abstract, length or word count? For example, if you have a case report, you can't go beyond 800 or 1000 words or whatever the journal prescribes. Scope, if you have a totally experimental study sent to a clinical journal, then it may not stand a chance. Similarly, if it's a research journal and if you send a purely clinical stuff, it also may not stand a chance. Is the article type correct? Have you submitted a case report under the section of case report, or have you submitted it as the original article? What is the significance? Is it a simple run-of-the-mill case, or does it have some kind of a teaching point? And what do the readership want, and what impact would your article have? So these are the factors that are taken into consideration in the initial screening. If a particular manuscript does not satisfy most of these, then the manuscript is rejected at the phase of submission itself. So within a week or 10 days, if you hear from the journal that your manuscript is rejected, that means that it was rejected largely based on the screening criteria, the priorities for that particular journal, and it has not undergone a due peer review process. Suppose some of these factors are missing and the manuscript is alterable, it can be modified, then it is sent back to the author for alteration. So that is called a technical revision or a technical review. So technical editor will screen the manuscript and send it back to the author saying that you need to correct your references, you need to put your results in this particular way, your graph should be like this, your table should be like this. All that has to be achieved before it goes to the peer reviewers, because peer reviewers have very limited time. They are the most scarce resource in medicine or ophthalmology or any scientific publication process. They have very limited time and you cannot bother them with a full stop missing there or a comma missing there. They have to be given a manuscript in a particular accessible format. So a baseline review always aims to ensure, as far as possible, that a manuscript is given to the reviewers or presented to the reviewers in a format that they can easily assess it. So once it reaches a stage for a peer review, it is sent for a peer review. So this is what the initial screening phase is. This happens in the first 3 or 4 days. So this is when I log in, this is what I see. How many are in editorial review, what category, in how many manuscripts are waiting for a decision, how many are waiting for a revision, how many have been rejected over the last 1 year, how many are under technical modification. So this is my kind of a opening screen that I see. And here I choose whatever that I want to work on, or any editor for that matter, whoever wants to work on a particular aspect, they would choose it and go forward. That's just the close-up of the screen. Now, once it passes the technical screening, as I said, baseline scientific review is performed by an assistant editor in IGO. Now, this is again by an assistant editor who is a very young individual. He is at the lowest level of a faculty, assistant professor or a lecturer, or somebody who is even a senior resident for that matter, who's competent in assessing an article. He does a baseline scientific review just to make sure that the article is optimized before it is sent for peer review. Now, if you think peer reviewers are very cruel, they want to bash you up for every small mistake you may or may not have done, that is very wrong. Peer reviewers actually are some of us. Peer review is an evaluation of work by one or more people with similar competence to the producers of the work. That means that your own friends and colleagues may be reviewing your work without them or you knowing that they are reviewing your work, because it is double-blinded in most of the journals. So if I get an article written by my own friend, I can possibly guess based on the case profile, but I cannot confirm whether it is written by him or her, because I won't know whose manuscript I'm reviewing. Similarly, the author will not know that I have reviewed. So it is a double-blinded kind of a review. So nobody will be unduly critical towards your work because they don't know who you are. There is no personal bias involved, or ideally it should not be involved at all. It is a form of self-regulation. Basically, in science, self-regulation is very important. So if your peers are equally competent as you are, they will be able to tell whether a particular article maintains quality, can it be improved further, and is the work credible or not. So the purpose of peer review is very Boolean, as I would say. It assesses the suitability for publication. Is the work true, credible? Is it reproducible? Is it important and relevant to the journal and its readers? Is the work communicated effectively? Is there an element of novelty to it? Is there any plagiarism? It also would help you improve the manuscript because they will comment on how to interpret results in an optimal way, how to reason out the discussion, how to present the results in a much better way. You'll get critical but constructive feedback and also some new and additional ideas at the stage of peer review. So how are peer reviewers chosen? We have a huge database of peer reviewers. Whenever somebody's manuscripts gets accepted, that particular person also gets added to the bank of peer reviewers because he has written an article and it is accepted. So he has some standing in the publication world, so he gets added. So similarly, we keep on adding good reviewers all through the year and we have a big database. But we don't preclude the authors from suggesting reviewers. Sometimes it so happens that authors may have written on a particular rare disease which general or regular peer reviewers may not have some experience with. So authors can actually suggest the names of 2 or 3 peer reviewers. That is perfectly acceptable. We may or may not send it to them, but authors can suggest it as part of the submission process. We can also accept peer reviewers as suggested by other reviewers. For example, I send an article to Meenakshi and she says that, no, I don't think I would be able to review it, but I have one more colleague of mine who may be able to review it. That is from a suggestion of a reviewer. That is fine. Reviewers may also be suggested by editorial board members and our own knowledge of the community. Now, this is a reviewer's score sheet or a questionnaire. It asks several questions. Does the manuscript contain new and significant information? Is the problem significant and concisely stated? Are the experimental and theoretical methods described comprehensively? Interpretation and conclusion justified by the results, which is very important. Is the abstract concise? Is the literature citations adequate? Is the language acceptable? Reviewer is supposed to answer as yes, no, and may even give a detailed description. He'll say see report. Then finally, he will give either accept, minor revision, major revision, or rejection as the result. So peer reviewer is asked to comment on whether the article should be accepted, whether it should be modified, whether it should be rejected. Acceptance without modification is extremely, extremely rare. You won't generally want to accept an article without even a minor modification. So it's very rare. So majority of manuscripts go for a major revision or a minor revision. In fact, major revision is more. About 60% of revision articles go for a major revision, which means that it will be reassessed. Major revision will also mean that it will go back to the same reviewers for reassessment. Whereas with minor revision, the editor or the editorial board member or the section editor has the independence to accept it once it is revised. So there is no need for a second review. So when an article comes back to you or the author for a revision, you have to look at the reviewer's comments very, very carefully. You have to be nice to them when you respond to them. You should thank them for positive comments. For negative comments, you should accept their views. Well, views can differ and try to explain it very politely. Don't take a kind of a confrontationalist attitude towards the reviewer because they haven't harmed you. Their intention is not that. They may have used some rough language that is individual, but then their intention is not to harm you or hurt you. It is just to point out mistakes or being critical. So you take it as it is at face value and respond to it very gently, as gentle as you can be, but making your point loud and clear. So your point should be loud and clear, but the language that you use should be quite gentle, apologetic wherever that is required, and thankful wherever that is required. So because your responses will go back to the reviewers, and if you are confrontationalist, they might take it in a negative sense, and that may lead to multiple sessions of review and re-review, and your manuscript publication may unduly get delayed. So you need to convince them, and generally not the editor. If the reviewers are convinced that your manuscript is good, then editor has to simply accept it. He doesn't have any much role. No, some manuscripts are rejected, which is unfortunate but true. In fact, 50-60% of manuscripts may be actually rejected. In some journals, it is even 90%, 98%. But when a manuscript is rejected, do you actually counter it? Generally not. Generally, if it is based on a sound reasoning why it is rejected, you don't go back and fight with the editor or the editorial board. Occasionally, but if you think that comments are not justified, they are biased, etc., then you can appeal to the editorial board for a re-review, which is very rare. Now, why do manuscripts get rejected? What are the problems? So all that is shown in red are the most frequent reasons. Poorly written manuscript, your work may be good, but writing may be very poor. inadequate or inappropriate way of presenting. That means you're very repetitive, data is all haywire, there is no organized way of presentation. Very poor description of the design, that means making it very difficult to reproduce. Some of this is excessive zeal and self-promotion. That means that this is the first ever case in the world of this particular disease, which may not be true. You may not have done your literature search carefully. So you should not be very, you should not self-promote yourself. You should not quote your own articles too many. Out of 20 articles that you have quoted, if 15 are yours, then that is self-promotion. And if you're confused or contradictory, your results say something, but your conclusion says something else, your discussion says totally different thing, that is confused way of presenting your results and discussion. So that is also one of the reasons for rejection. And if the reviewers feel that essential data is omitted or doctored or ignored, that means that you have not talked about your complications. You have only talked about the positive aspects of the study, hidden all the complications behind. You don't want to talk about it. That is something that is negative. It's very boring. You don't make any point at all at the end of the manuscript. That is again something that is considered negative. And if you ignore important work of others, if you don't cite it, also that is considered negative. Most important reason for rejection, of course, is plagiarism. So we have a built-in software in IGO for any journal in that matter, for that matter. You can actually upload that particular article on a software called iAuthenticate or anything, something similar. And sometimes you'll be surprised to find that the plagiarism index is 48%. That means that 48% of this particular manuscript was copied from other sources, which is very bad. This is not considered good publication ethic. There are many other publication ethics also, and there are guidebooks for editors as to what comprise publication ethics. There are ethical responsibilities of the editors, authors, referees, and even the publisher. Editor is supposed to be efficient and fair, ensure confidentiality. That means I cannot talk about your manuscript to your colleague who may copy your idea. Make a final decision on a submission in a reasonable amount of time, has to select referees in a fair manner, cannot assign all strict referees to one manuscript and all loose referees to another manuscript, and act upon allegations of scientific misconduct and deal with appeals very appropriately. Authors have to be honest. There should not be multiplication factor. If you see 10 cases, you cannot say I've seen 100 cases of this particular disease. You have to be very honest in terms of number, your data, and the data analysis. And you should give due recognition to published work of others, due acknowledgement to all the contributors. You cannot leave out a particular co-worker. If you have used a particular co-worker or a colleague to get a set of cases, you cannot leave him or her out, which often happens. If a particular person leaves the hospital or a department or an institute, normally, people move their jobs all the time. And if you're using 75% of his cases or 50% or even 10% of his cases, you cannot leave him out as a contributor. You have to include everybody who has contributed cases as a contributor, or whoever has participated in the study. And you should not do salami publishing. This is called undue fragmentation of work. You cannot say I'm publishing only one particular aspect of this work in this journal and I'll reserve complications for some other journal. That cannot happen. Or you can say just 40 cases published here and next year you publish 58 cases of the same disease somewhere else. So you cannot do that, right? And at one time you should not submit to more than 2 journals. And reviewers also have a responsibility of not taking personal advantage of the data, not getting biased with conflict of interest, and maintaining confidentiality, being objective, and being timely. So if you have jumped any ethical boundaries, then there are very severe penalties. Finally, after this, once the manuscript is accepted, it goes into the production line. What does production involve? It involves copy setting, copy editing. That means that somebody in the journal's office goes through the manuscript and picks out spelling mistakes which are inadvertent, or language editing, sentence construction, paragraph, everything they look at, and then they type set it. Once it is typeset, it goes back to the author for what is called proofreading. And it is generally timed 24 to 48 to 72 hours is given for proofreading. You proofread it, send it back to the journal's office, and then you will get a final copy again. If you are still not satisfied, you can proofread even up to 3 or 4 times until you are satisfied that everything is perfect at that stage. Then it goes for printing. Now, once it is printed, is the game over? Game is just begun actually. If you're in an academic world, publishing a manuscript is just a game begun, because you talk about what is called impact of your article. Unless you are cited, you have no standing in an academic world. Just by the fact that you are published, that's okay for a beginner. You get a few publications on your CV. But somebody at a particular level of career, say suppose you want to get promoted as a professor, then you look at your H index, you look at your G index. These are all indices of the standing value of your past publications. And for a journal, it is the impact factor. There are two ways of measuring the impact factor. One is called Scopus, the second is called Web of Science, and most of these have a common pool of journals which they measure. So impact factor is the oldest objective measure of the impact of a journal. This was started in 1963, and about 15 years ago, H index and other sort of indices have also come in. It's a simple way of calculating impact factor is this: total number of times the articles were cited during 2 previous years divided by the total number of citable articles in the journal during 2 previous years is a journal's impact factor. That means that if your journal's articles have been submitted 100 times in the last 2 years, and if you have published 50 articles in the last 2 years, your impact factor is 2 for this year. That means we take 2 previous years. If it is 2020, you take 2019 and 18, and the impact factor is released for 2020. Now, so that's it basically. So a lot goes on behind the curtains. Curtains are not opaque, they're transparent. At every stage you can track your manuscript and see where it is. It's not an opaque curtain. It's a transparent, I would say translucent curtain. You can see through it, but a lot goes on behind it, and finally we come out with a 300 page or a 150 page, which you call Indian Journal of Ophthalmology. Thank you so much.
Thank you, sir, for the excellent presentation. It was beautifully covered. Now, being young medical researchers, we all have heard about PubMed, but are we actually well versed with it? So, without much further ado, I would like to invite our next speaker, Dr. Vivek Gupta, sir, who will be throwing light on how to do a PubMed search. Over to you, sir.
I am audible? Yeah. So basically, we have all heard of PubMed, and the first thing that we do when we are researching on a topic is we either do a Google search, or these days we do a PubMed search. What is PubMed? PubMed is a big database of articles. It has over 25 million articles which have been indexed into its database. Journals have been indexed in PubMed from all over the world. Articles from multiple languages, journals of multiple languages are included in this database. It is very user friendly. Often you get links to full text articles, which are often free. So, once you have identified the right article, you can go and access full text very often. And, everyone knows PubMed. So, that's why it's one of the most commonly used database engines for researching, especially medical literature. As of today, approximately 7,500 journals get indexed in PubMed regularly. And if we go back historically, there are certain journals which have been indexed even from the 19th century in PubMed. That is only for a very selective few journals. Largely journals, it started picking up in the 1940s, 50s. Initially, the database used to be made available to people on compact discs. CDs were available, there would be a big set that would come into your library. you would get the disk into the computer and search the database and change the disk, search again. But these days with internet, all these things are just a click away. And this is the URL pubmed.ncbi.nlm.nih.gov. It's a big link, but typically we just go to Google, type PubMed, and there the search engine is. So the look of PubMed has changed very significantly in the last 6 months or so. This is the new PubMed interface. They still call it in beta. And, this is the screen that greets you as soon as you visit the PubMed site. And just like Google, you have search PubMed written right in the middle. Just go ahead. And the simplistic way would be to just type your words, say burden cataract surgery in that search box, hit search, and you would have your search results. So even these search results, this is the new interface of PubMed. This is very different from the way it used to appear. The results used to be on the left-hand side and some of the filters would be on the right-hand side, but well, this is nicer looking. So few things, this is the very simple way of doing it. You type a few words and you get the relevant results. A few new things have been added to PubMed now, just like Google. If you start typing CAT, cataract, so it will, show you the possible words which match. In case you have done a spelling mistake, then the spelling will get auto-corrected. Very often we are not interested in, what all articles meet our search criteria. We are only looking for a very specific article, say pediatric cataract by Coker et al. So we would just type the article and the authors, and it would match the closest citation, the closest article, and show that to us and allow us to go directly to that article as well. On the left-hand side in the current search interface, you have various options for sorting. On the top and right-hand side, you have the sorted by best match. So the most relevant articles are visible to you first, but you can choose the display options, click there, and sort by best match, most recent or by publication date. So very often, if you're interested in, what happened recently, was there something new about, say, burden of cataract surgery in the last 2 years or 3 years, you may want to sort the results in a descending order by publication date so that you have the latest results first. You also have filters available to you on the left-hand side, the red boxes which I have drawn here. So in these, you can choose to restrict your results only to full text or free full text articles, to systematic reviews, meta-analysis published in the last 1 year, and there are more filters also which are available to you. Earlier, you had to click on next page and a new page would open in the search results. Now you have a show more button at the bottom. You click on this button. So initially you'll be getting 20 results. Show more, you'll be getting 20 more results, and the cycle will keep on repeating. If there is an article that you are interested in, you click on the article opens and the abstract is visible to you. Now, how I typically do it is I would do a control click on the title so that the article opens in a new tab of the browser. It doesn't open in the tab that I'm currently using. How that helps is that, my search results are there in one browser window. My article is there in the next browser window. I can read through the abstract. If it is, I find it useful, I keep it open. If I don't find it useful, I close it. If the article is open in front of you, you also have the links to the full text. Here we have the link to Walter's Kluwer journal site. Very often, many of these articles, you have the full text available in PubMed Central. So PubMed and PubMed Central are kind of two sister sites, you can say. PubMed is the search engine. PubMed Central is where the full text articles are kind of deposited and are available to you. So not every article goes into PubMed Central. Only few journals submit their articles into PubMed Central, including the IJO. In the abstract, when you're viewing the abstract, you also have the option of viewing similar articles and cited by articles. Now, this has the huge potential of helping you in your research, because automatically PubMed will try to identify the most similar articles. Also, there is a great chance that articles which have cited this one, the one that you are seeing right now, they are also related, right? So you can go to similar or cited articles and go ahead more further and further into your research. Now, some of the common issues that are faced, if I just do a very broad search, I may get thousands of results. So how do I narrow it down? So one thing would be that, instead of using general search terms, make more specific one. One example, low back pain, instead of just searching for back pain. We can increase the number of terms that we are using in our query. And again, the filtering options that I showed you on the left-hand side of the results, you can also use them. Very often there are there may be too few results that you are getting. Now, that may be, because your terms are very, very specific and, the combination is uncommon. So really there are few articles, but I would actually take a step back and see, maybe if I remove one or two terms from my query, do I get a broader set of results which I can use? Also, we must always try to search using alternate or synonym terms. Once you have the results in place, what do you do with them, right? One is obviously you are going to read them and identify the relevant results. But as a best practice, I always try to save the relevant articles into one of my citation softwares. I use Zotero most of the times. It is free, it is open source. With the click of a button in the browser, I can save the articles into my Zotero library and use the same articles when I'm writing up a manuscript, when I'm citing, formatting. So it takes care of a lot of things for me. Few additional things, especially if you're doing research for your thesis work. So you can create an email alert for the search. So what will happen is that PubMed will send you maybe a weekly or a daily or a monthly email with the updated articles that meet your criteria. It's a good way to keep up to date with topics that you are interested in. They may be related to your projects, to your thesis work, or an topic of general interest to you. You could also create an account in PubMed these days and save your search results or create a collection within PubMed. So, the next time you go to PubMed, you can just go to your results query and rerun the same query again, get updated results, see the citations that you have saved. And there are many other options which are available to you as well. So this is how it works with Zotero. So I have the article open on the left-hand side. So I have the article open here, and within my browser here, when I have installed Zotero on my system, I get a small link which says save to Zotero. I click on that, and in the Zotero application, the article has become a part of my library. Now this article is available on my computer right now in Zotero, and I can cite it in my manuscript. Always use a reference management software, always. This is a screenshot of email alerts. This I'm getting, so I'm interested in refractive errors among young children. So I have created this complicated search which talks about prevalence or survey and blindness or visual impairment and ophthalmology. So this is one, on April 14th, I got these two updated matching articles which have appeared in PubMed from the previous mail time. That said, we can create very, very complicated queries as well. One example of the query you saw here in the search, when you see all these brackets, ands, ors. So let me show you how to do it easily. So if you're on the PubMed homepage, under the search bar, you have the advanced search, text which is written. The link is there. If you click on that, you get an interface which is something like this. Okay. In this interface, first of all, you can choose, I want to see, say, for example, articles which have been authored only by, say, Murthy et al. So author Murthy. Okay. Once I select the criteria, I say I want author to be Murthy. And then on the right hand side, I can add that criteria to my search. So I can say add with and. Then I can go ahead and say, I want to search for cataract, but it should only be in title and abstract. So from the drop down here, I'll select title abstract, and the term I will add cataract. And I'll say add with and. I want to say that I want articles which were only authored after 31st of January 2018. So I choose date create. I put the date. So I'll get two options, date from, date to. So from date, I'll put it as 31st January 2018. End date, I'll put today. And that's it. I again will say add with and. So as I keep adding my query parameters, so this query box below will keep on getting updated. And thereafter, I'll just hit search, and that will give me results with these query parameters filtered. So here, with all that query which I had created, I have got only 8 results. So this is a good way if you want to restrict your, search. You go into advanced search and, create visually your complex advanced query. As you can see, you can combine searches using and ors. The other secret to advanced PubMed searching are using tags. And one of my personal favorites is the title abstract tab. Okay, so if I'm interested in cataract and burden, so there is very high likelihood that the article would include both these terms either in the title or in the abstract. So I'll create a search cataract. After that, I will write within square brackets TIAB, title abstract. Then I will write and then I will write burden. Again within square brackets, I will write TIAB. So from the main PubMed window only, rather than going into that advanced builder kind of an interface, I can just write my query and get my results. So there are multiple tags which are available: author, journal, publication date, text words, and you can combine them with using and or not. And you can group the conditions using these round brackets or parentheses. So here I have a query in which the publication date of publication, DP, is from 1st January 2019 to 1st December 2019. And the articles must contain either the text word trachoma or trachoma in title or abstract. So by making use of and, or, and these round brackets, I have created an advanced query. You can also use wildcards. So cataract star would, corneal would match anything which is cataract followed by maybe a hyphen and a word. So it will expand your query that way. If there is a specific phrase that you want to search for, say corneal transplant, then you can put that phrase in double quotes. If you do not use double quotes, then the search would be corneal and transplant. Whereas if you use double quotes, it will be corneal transplant, the phrase that will be searched. You can also use the tag TW for exact search by a phrase. there are a lot of resources available to use PubMed more effectively. Within the PubMed, you have online training resources which are available, quick tips, tutorials, webcasts, videos, etc. Even on the main PubMed homepage, you have the learn icon right there available to you, which, if you spend maybe 15 minutes, 30 minutes on it.
Sorry to interrupt you, sir. We are running out of time. I request you to kindly wind up for you.
Yeah. So this is my last slide. So yeah, that's it. I think.
Where you continue, you finish it. You take your time, finish it. You have something more to say, you can say.
So basically, I just wanted to say that if you are talking about PubMed search, one of the things that you would read mesh headings. So which are medical subject headings, which are basically a vocabulary that PubMed uses internally, which contains synonyms, similar names, etc. So even if you have not used an exact name word in your search, PubMed does a reasonably good job of finding alternates and even including those in the queries. But you can always explore, the students can always explore that mesh database to look for maybe more relevant words which are similar to the concept that you are interested in researching, and use those terms as well in the search. So that's it, sir. This was, in a brief about PubMed. So I'll be happy to take questions.
Yeah. Thank you, Vivek. So thanks to all esteemed faculty for enlightening the students and moral boosting them for preparing for the exams and giving them the tips which you have learned on lot of years of your hard work, 30-40 years hard work of teaching experience. Sir, Dr. Mangadogra, sir, first question is for you. Dr. Mangadogra, sir, unmute yourself. Unmute yourself, sir.
Yes.
PG is asking you, sir. I realize that time is of importance and concise answer are where to go, as you told. Some of my teachers have said, longer my answer sheet, the more marks I will get. Is it true, sir?
Well, I think that's not true. I must say that. You see, we have a very long experience of going through all the notebooks from the biggest institution like maybe All India Institute, RP Center, to a smaller medical colleges. So nobody is reading the entire, you see, question, the answer sheets. So that's why I mentioned that if you are more concise, you are bold, you have drawn a nice diagram, and you have highlighted, I think the chances are that you're going to get good marks and you're going to definitely pass. But in case you write what you said, so many pages and fill up so many things, and they may be not relevant, and at times they are also at the expense of not answering the questions later on properly. So I would say, I think what is required is that you be more concise, and if you are concise and you look at those aspects of making drawings, enumerating important points, underlining them, and labeling, I think it goes a long way.
I totally agree with you, sir. My father has been a teacher, as a professor, and a principal. I used to see him checking the copies. In 5 minutes, he checked one copy. I asked him, student has written 20 pages. How can you check in 5 minutes? He tell me, I can judge from in the 5 minutes what he has written there. So if you have concise answer, you have made a diagram, flow charts, diagram illustration, that one page will be more than sufficient than your answer sheet of 10. But if you don't know, there's a tip that Dr. Dogra will not tell you. If you do not know the question, much question, then you can write as many as paper sheet, just to confuse the teacher. If you do not know the question. That's Santosh. Sir, one question for you.
Santosh, sir. Sir, you are asking question to Santosh, sir, or I will ask?
Dr. Santosh, one question for you. If there is an article ready for publication, and then I find a mistake in it, as it is going to print, what should I do?
You can correct it. Even up to the stage that it is printed, it can be corrected. And if after getting printed, if you find an error, you can always issue an erratum, which will be published in the next issue of the journal.
Okay, sir. Sir, another question for you. If my article gets rejected once, so how can I resubmit it to same journal?
Not to another journal, yes, not to the same journal.
And sir, what is the difference between the paid journal and the IGO? Because IGO is also charging the fee.
Which journal?
What is difference between the paid journals and the IGO?
Oh, okay, predatory journals. Yeah. There are predatory journals which run by charging people for publication. Those are called publication fees. But IGO is mandated by the AIOS. It is in the AIOS constitution that we should charge for color reproduction. So if you have a color image, that has to be charged by IGO, because IGO runs on membership money. IGO does not have any income at all, except by advertisements that companies give and the membership money that individual pays to AIOS. IGO has no source of income. So for color printing, IGO charges money, which is very modest. In fact, what we charge is charged in dollars for international journals. We charge in rupees, 70 times less.
And so one more question for you. That's Dr. Sahiba. Can a prevalence study be published?
Yes.
Without statistical analysis?
No, nothing can be published without statistical analysis. It has to be duly.
In what instance can be article be published without statistics?
Case reports, photo essay, ophthalmic images, or a short case series of 5-6 cases.
Santosh sir, one more question from our special invitee, Srishti. Srishti, can you unmute yourself and ask question to sir?
Actually, my question is for Dr. Santosh, sir.
Yeah, tell me.
Sir, which would be the best article for residents, budding ophthalmologists like me, to start with?
To read or write?
Write, sir.
To write, okay. Case report, easy. Photo essays, ophthalmic images, very easy. If you see something very good, slit lamp image or a fundus image that, if it's rare, if you make a small story out of it, absolutely fine. Something that involves a systemic disease. If you find an ophthalmic condition in a patient who has a dermatological disease, so that association is something that you can easily bring out. And all your theses can be published if it's done well and written well.
Santosh, how can we motivate the young generation to in writing in the journals and everything?
I think they should realize it themselves, because it has value addition, which is very significant. If some
you have to tell them, Santosh. Do you have to tell them importance of the publication in their journal when they are going for the fellowship?
Absolutely, it is not just fellowship. It is even when they go for their first job. People look at your CV. Especially in an academic institute, or you can ask Deepak. It's very difficult to get a promotion in a government setting without having articles. Similarly, to get into a government job, for that matter, if you want to become a lecturer or an assistant professor, after everything else that you have, publications count a lot. Fellowship, of course, it counts a lot. If you apply for a kind of a travel grant, APO travel grant, your CV matters a lot. So everything beyond residency CV matters a lot, and the only way to add authentically to your CV is to publish.
Deepak, I will like you to add it, because Deepak is the youngest person here who is getting promotion very fast. So he should tell him how he's getting the promotion, what he is doing for the journal publication, etc. Deepak.
Don't tell other things, just the publications.
As sir is saying, as per the MCI rule 2, publication is mandatory part, because it is the part of our essentiality. If we didn't fill our essential criteria, then didn't be screened or for the interview. So interview is the second step. First step, like practical. Practical is the second step. First is your viva. First is your theory of the DNB. Similar is first you have publication, so that you can fulfill the screening criteria. Then you will be selected in any interview. Santosh sir, one last question to you. There is some question from Neelam Burma. She wants to know how I become an member of editorial team.
Well, it is, first is that if you have to be a member of the editorial team, then you have to be a good reviewer. Reviewers are also assessed. The way how prompt they are with the reviews, how rapidly they turn over a manuscript, how accurate and good their assessment is. reviewers are assessed by section editors. So there is an assessment phase. If you are a very good reviewer, if you review 20-30 articles in the 6 months or a year, then you're tracked. In fact, there are awards for good reviewers also in IGO. Every year, 10 of the best reviewers get awards. So those are up for inclusion into editorial board. It's simple. It's all based on merit, mostly.
Dr. Meenakshi?
Yeah. Meenakshi ma'am is not there. Meanwhile, we can take questions from the
Dr. Dogra sir. Dr. Khurana sir, I can ask you then.
Sorry, I'm here.
Yeah, ma'am, yeah.
Just muted. Yeah,
ma'am, is there, Dr. Abhishek Sadeva is asking, is there any software to practice the diagrams or application?
Software to practice diagrams.
Diagrams.
I'm not aware of. No, I'm not aware of, but there are many. There are many PowerPoints available for free, which talk about corneal diagrams and retina diagrams. There's no point in using a software. You're going to do the old-fashioned way in the exam. Exam is going to be old-fashioned way, so you might as well just practice it that way. Not get used to something fancy, and then you find you have color pencils in the exam. I mean, that is what I would think.
Just to that diagram, you have to practice yourself for the books and from the.
Yes, how are you going to? Yes, how are you going to take it to the exam? I mean, the exam hall. There is no software. This is not an online exam. It's still a written exam. So you have to practice with your coins and your bangles. That's the way to do it. But there used to be some of the pharma companies used to give a very nice stencil, but I have looked online and I've not been able to procure it. If I mean, the ENTOD could probably take it up. I mean, just as a request, I think it would be wonderful to have a stencil available with showing a slit diagram of the cross section of the cornea and anterior segment, and also circles like this to draw, and a nice circle for the fundus. I think that would be very nice for the students to have.
Sir,
any question by you? Any question to you, to any faculty by you?
Dr. Sneha can ask.
Saloni, Neha.
Am I audible?
Yes, you are audible.
Good evening. I'd like to ask Dr. Meenakshi. Ma'am, sometimes during the practicals, no matter what we do, sometimes we have a bad downfall. And the confidence of the student you lose it. And then the next few questions, even though you know the answer, it becomes a little difficult to get back up. So how do you suggest we deal with such a situation? Actually, I had a similar question for Dr. Dogra as well. How to approach the never heard questions in theory and in practicals.
Okay.
Dr. Dogra, you want to answer first? Do you want to answer first?
All right. I think you may encounter such a situation once in a while, especially when something which has come up new or is something in the recent advances where perhaps it has been missed. So, and there, I think that's why I said you have to be doing all your questions, right? Like if you start with the best questions and you go to that one last, you are not going to, if you suppose get OCT angiography and you don't know a ABCD of that, don't write something which is totally off the track. So that is not a good thing. But what you can do is that you can keep such a situation to the end. And if you don't know anything, then it's better to leave it. But otherwise, most of the time, I think even if you have a little bit of an idea, what we have seen and I have experienced, that in the last couple of questions, you might have just about 3, 4, 5 lines written there. But if they are relevant, we tend to give some marks. Of course, if it is totally relevant, then one is going to get 0 for that particular question. So that can happen. Yes, Meenakshi.
So coming to practicals, a couple of things. So one is, I'll give you an example. For example, if you're asked about my earlier case that I presented was a ptosis, and if you're asked, why do you want to examine the pupils? And just imagine that you're completely blanked out of the word honor syndrome. It's just not coming to you. So sometimes it is nice to, and already one or two questions you have not answered, perhaps. So it's a good idea sometimes to steer the examiner slightly towards something that you know. For example, you can always answer saying, in oculomotor palsy, it's important because we divide it into pupil sparing and pupil involving. And then a lot of examiners love these areas to question. And so they can just then follow that path, and you may have escaped another, bottomless pit that perhaps you were dropping into. That is one. The second thing, like I again told you, long silences, and fumbling around sometimes does not help you, because everybody has allotted a certain time by which you have to finish the viva. So if you are totally clueless, if you come into your ophthalmology question and you're just clueless, just say, sorry, I'm not sure. Go on to something else where at least you'll be able to answer. I think that is that's a good way to make things go towards you.
Thank you, ma'am.
As she has rightly said, that whenever you do not do any answer, try to keep the attention of the your teacher to the other direction, but never lose your confidence. You should mentally prepare that some questions will be asked which you don't know. So one thing, good thing is keep smiling. Do not show the examiner that you are losing your confidence, you don't know anything. Just keep smiling, so she will ask you another question, because always teacher want to see your confidence. They know that you can't know each and everything. Even we can't know everything. So it is not to lose the confidence. Just keep confidence yourself and keep smiling and wait for the another question to come.
Next is Dr. Tina. You can ask your question.
Any other session where Sonali?
Am I audible?
Yes.
Yes.
Sir, I'd like to ask a question to Kurana, sir. So what are the aspects and questions should a resident be familiarized in biostatistics? Like in DNB, we regularly get questions on biostatistics.
Dr. Kurana, sir.
So basically, yes, sir. Basically, all basic statistics we should know, because we are doing one thesis, we become well conversant with this. So sometimes to practical examination, this may be asked, or sometimes there may be small note on that. So basic, you should know all what is p-value, what is the t-test, what is fair t-test, what is Pearson coefficient. Common things at least you must know. Detail, it may not be must that if you don't know, but common statistics must be known. What is incidence, what is prevalence? Sometimes you are not able to even differentiate what is incidence, what is prevalence. Then it becomes very difficult in the examination. And I also want to say something about the publication to the residents. And here I will like to tell them that the thesis is most important. If they really work during their thesis, they can get 2 to 3 good publication from the thesis, and then they have a good moral boost up. Here I will also like to say, sometimes I always say it is just like a marriage. The teacher as well as the students, if they both are proactive, then you get very good article and from the one thesis. My first article was from my own thesis, that was in experimental eye research, immediately a year of my passing it. So it made a lot of difference in my perspectives. Similarly, my first PG was allotted to me. We had 4 articles from his thesis. One was in the International Journal. So thesis is the time when if you really devote time, you review the literature also, then you learn the statistics also. So thesis should not be taken lightly, basically. But some students think they don't want thesis, it is of no use later on. But I will say they must concentrate on thesis and work hard on thesis. And this will pay them long academically in their life. This is what I want.
Sir, one question is for Dr. Azad, sir. Azad, sir, kindly unmute yourself.
Yes.
Sir, my question is to Dr. Azad, sir. I am the third-year resident, and if sir is my examiner and I have allotted a case of ROP, how can I face him?
In fact, I was going to say that there are different kind of examiners. Everybody has talked about the student. Look, this is what students should do. This is what he should not do. Picking up the thread from the discussion. And as one of the students said that when I appear in the exam, in the theory, in the Viva exam, and the examiner is asking a question, and I do not know, and then what should I do? And then somebody said that you should divert the examiner. It's not easy to divert the examiner. Everything depends on what kind of examiner is there. Sometimes there are normal examiners. When the normal examiners are there, like if I am there, if I have to ask question on ROP, I will ask the basic things. I will not ask you whether anti-VEGF is used or not. I will ask you what is retinopathy of prematurity, whether it is a developmental disease, whether it is an anomaly of the vessels, where there is prematurity there. I mean, simple questions, you know. I don't want you to know everything about retinopathy of prematurity, especially on the on the side of management. But I definitely want you to know what the disease is and how you will diagnose. You may not be able to diagnose, but at least tell what are the points in the diagnosis. So it depends on the examiner. No, some good examiners are there, normal examiners like me. If I go there, my intention is not to fail the student. I will never fail until and unless the student is herself or himself not capable to pass. This is my first motto. So that is what, you know, it is the examiner also which makes a lot of difference. If somebody is fumbling, somebody is stumbling, what I do, I say, or somebody is nervous, you go and sit there, you go there for 15 minutes, and in the meantime, I'll examine the another student, and then you come back to me. So that should be the attitude. The idea should be to examine the student, that the student has a knowledge on the subject so that he can practice it outside. That should be the idea. And here I would also like to say, there are some cranky examiners. The basic idea of examination is to test the knowledge of the student, not that the examiner should show his own knowledge. His knowledge, he has his own platform where he can share it with his own colleagues. So these are the problems. This problem is there. The student should be examined to his knowledge, which is required at that point of time. This happens also in the presentations. When we go for the presentation should be only to the subject and what level of audience is there. If I have a PG student, I'll talk about the PG level. If I have my colleagues with me, I will talk about the research and the recent developments. So all these factors are very important. And if I have to conclude this session, this was a wonderful session, but I would still like that little pruning is needed in this session so that we are more, you know, objectivized. Because if we are more objectivized, the students will learn more. You know, I was thinking when he was talking about the PubMed, I was thinking, what is the use of PubMed for these postgraduate students? But there is a use. There is a use. And what is the use? The use is when you go for your thesis presentation, or when you go for your protocol presentation. When you go for your protocol presentation, at that time, you have to find out the articles which have been done on a particular topic where you have to start your thesis. There, PubMed will come into your role. And therefore, it is very important. Why journal is important? When you finish your paper, thesis, then you must present, you must publish your paper. As Santosh told you about the different, you know, aspects of publishing an article in the journal, that's very important. And of course, the other aspects have already been, you know, presented to you. So, you know, I mean, for the students, again, I will tell you one thing. If you have done a good residency training, like, you know, when I entered in RP Center, I was told that this is a 3 years rigorous imprisonment. I was told that this is a 3 years rigorous imprisonment. And truly, it is a 3 years rigorous imprisonment. If you have done well, if you have, you know, seen cases, if you have worked in hard in the wards, if you have attended all the lectures, there is no reason, no examiner in the world will fail you and you will, you know, come out with the flying colors. So that's what I wanted to tell you. And I think, thank you very much for this wonderful session. And we hope to do still more. I don't know, you know, we'll do something more. Thank you so much.
Thank you. Any question to Dr. Vivek? Any special invitee having any question?
Dr. Dogra sir?
Yes, please.
Dr. Dogra sir?
Yes.
Sir, your views about this webinar, what you want to say to them, and last in the motivating to boost their moral and mood of the PG student going to appear in the exam.
Well, I think
before we say goodbye,
I think it's a great idea to have a forum like this where you see all our residents, whether they are doing DNB, MD, MS, or DO, they'll have their queries also sort of clarified and know basically that what way we should be proceeding, especially with their studies. It's not only how they study and what they should study, how they should prioritize, as well as in the long run, what Professor Azad already said, even Dr. Khurana said. And it's not only that we have to sort of just cram everything. I think if we are more practical, we work hard, as Professor Azad said, that you utilize those 3 years. And if you have a problem that facilities are not available for good teaching, so these are a forum. You look at the forum which is created by Santosh. I think he has created a great forum which is so popular that he gets more people in his PG course and they get benefited. And we are surprised that they are even going from like institutions like ours. They feel that they get more benefit even as far as their studies are concerned. So we need to be doing more for education, medical education. And that is a setback at this time. I'm sure Professor Azad Khurana would agree with me, and so all of you, that at this time somehow we are not interested in teaching. We are interested in other things. And that's a sad part. And it's becoming more and more like that. And that's not a good thing for our country. We need to train these teachers. That is what I feel. We need to train from peripheral colleges because they have no idea. They have no exposure for what is being done in the present. Sometimes they don't even have seen a phaco machine. And they have not seen phaco machine. So what do you do? Everybody talks about phaco. So those are the issues I think we need to address at length. What to talk of other things which we do, like OCTs and OCT angiographies and others. I have myself seen that. When I went to a very good college, their professor HODs, they have never taken out that indirect ophthalmoscope. So they were not giving that. There was one available, but inside somewhere. So that is what we'll have to change our mindset, train people more. And we have to tell our PGs, we have to change their perception also that they should get trained, how they'll get trained better. I'll just end with that. Like, I think it's a good model in RP Center, like in our institution, we tell them to buy everything, including indirect ophthalmoscope, a streak, a trial set, everything. So that if they have their own, even in the peripheral center, they'll do it, they'll learn it, they'll force their teacher to do the same. So these are some of the things. I can go on and on because there are a lot of problems with the medical education in our country. Thank you.
Thank you, sir. Dr. Meenakshi ma'am, you have been associated with teaching so long. You have seen a lot of ups and downs in the students' life during examination. Your last comment to moral boosting of the students and to guide them. Dr. Meenakshi ma'am and Dr. Khurana sir.
I wanted to say, first of all, I wanted to congratulate both of you and your team for a fantastic forum where you have helped the PGs by offering the nuts and bolts of really how to go about important aspects of their residency, right from Dr. Khurana's as how to be a model resident, to theory, to practical exams, to PubMed search, which is an integral part of anything you do today. If you want to practice evidence-based ophthalmology. And a wonderful talk by Santosh. And I think you've done an exemplary job of putting this program together. So congratulations to both of you. But I want to end on an optimistic note, saying that I have been associated with the ARC of the All India Ophthalmological Society for almost 5 years now. And we have done the Teachers in Ophthalmology program as a pre-conference program every year, year after year. And I can say that there is a definite increase in the cadre of young teachers, people who want to learn how to be good teachers in all aspects of teaching, not just lecture skills, but how to be a good surgical teacher, how to give feedback to their students. So many aspects, I find there is interest now amongst the youngsters. So I think good times are ahead in medical education. And my appeal to all the postgraduates is this, and I say this every time, that when you finish your post-graduation and wherever you join, before you jump into private practice, if you can devote the first 4 to 5 years to a teaching institution and give back what you have learned, I think you will do a great service to improve the ophthalmic education in our country. That's all I have to say. Thank you.
Thank you. Thank you.
Thank you, ma'am. Dr. Khurana, sir.
Yes, sir.
Deepak.
So I will want to start from where Madam has ended with the optimistic approach, because what I have seen over the years that now the students are becoming proactive undoubtedly, and they have their own gadgets like indirect ophthalmoscope, gonioscopes, which are not even available sometime in the government medical colleges. And these teaching forums, like as Dr. Dogra has already mentioned, by this PG forum and Dr. Santosh, DOS, and even RP Center, so many PG forums are available for them to get updated. And I must appreciate that our residents nowadays are more digitally more sound than us even. They make slides for us, they make videos for us. So this is very good, and their documentation has become much better than what we have in our times. So with this, I will like it's an optimistic approach. And undoubtedly, there is some problem somewhere in the sense, the big institutions, and they have so much advances, and even the examiner, they expect so much. But I will still like to tell to the students that they should stick to the basics. Basics should be very clear in these 3 years. And if they don't tell the basics, only then examiner is annoyed. But if they don't take the advances, nobody will fail. But if you tell, definitely you are going to get better marks. That's there. But basics should be very, very clear. That is most important. And all these 3 years, they should make a schedule to read daily. They should see the cases and study them in the books, what is it, and discuss next day with the seniors what was the problem in this case. So I think the future is rather very good. There's a lot of exposure to the students everywhere. Google is also full of that. So many videos. We never saw video of the surgery, and now you can just see the video and you can start doing yourself also. So a lot of avenues are there for the student. They should be very happy and lucky, but at the same time, they have very tough competition also. So thank you very much for asking me to speak, and it was a wonderful webinar.
Thank you, sir.
Definitely very useful for the students.
Thank you, sir. Our efforts of making this PG forum, Deepak and me, was the same. We are not the alternative to the books, but we are the guide. We are bound to become the guide to the students, where we can guide them what is right for them, what is wrong for them, where they should approach, or how they should approach. The aim of this platform is the same. Dr. Santosh, you have a vast experience of the association with postgraduates. What do you like to guide them?
Sir is not there. Sir has moved for some urgent work. I think
Dr. Vivek, your views on this webinar?
Sir, I think these webinars are excellent, and these are a good way to reach out a large number of students across the country. And it's a win-win situation for everyone. And kudos to you and to the team for taking the lead and initiating them.
Thank you. Dogra sir, all our PGs you have seen here are the first time on the web series. So what you can say about their confidence and the way of conducting these webinars?
They all are the PGs, sir. That's right.
First time
they were asking the questions.
The national platform, except Saloni, she has done previously with us.
I think they did so well and very confident, and even the way the whole webinar was conducted and their participation, and they were very, very all the time active as well as ask questions. So I think that is what we feel should be expected from all the residents, and that was great. Absolutely.
and we expect them to go in the exam with the same confidence.
Yes, and they should go with the confidence, with a cool mind, with full relaxation, and the examiners or the exam is not something which is end of everything. It is just the beginning. So you have to be just cool, and you go there, as already emphasized by everybody, you're going to go through that very smoothly. So good luck to all of you.
Deepak, conclude. Deepak, conclude.
Thank you, sir. Now, Saloni can give the vote of
Saloni, conclude the session.
You can invite if anyone wish to say anything about the PG forum.
Any of the special attendees want to say anything about the session?
Anyone having any question or wish to say anything?
I just like to thank PG Exam Forum for this opportunity, and like everyone said, the stalwarts of Ophthal were here, but I'd rather call them our role models. And it's a great opportunity to get to interact with you on such a personal, though virtual, but personal level. Thank you.
Anyone else would like to say something?
I would like to thank Dr. Deepak sir for giving me this opportunity at such an early stage of my career to be a part of this webinar and to interact personally with all the renowned faculties all over the country. And I think PG Forum is an excellent platform for all budding ophthalmologists like me to learn and to grasp maximum information and to become like our renowned faculties all over the country. Thank you.
Before I wind up, I would like to request you all to go through this AIOS online survey. It is an interesting survey on post-lockdown challenges to an ophthal surgeon, and it would hardly take 5 minutes, so kindly go through it and fill it. And to join our PG examination forum group, you can message your name and college name to Dr. Deepak Mishra sir. The number is being displayed on the screen. It's 9415360338. And I would like to extend my heartfelt thanks to our chairperson, sir, moderators, and prolific speakers. We all had the privilege to learn from you through this virtual platform. I would also like to thank my fellow special attendees for making the session so interactive, and to ENTOD Pharmaceuticals for logistics. Last but not the least, I thank you all residents and attendees of this webinar to make it a success. Thank you all.
Thank you, sir. Thank you, everyone.
Thank you.